Well, good morning, everyone, and welcome to the Nuffield Trust Summit and to this session where we're looking at the tension between central and local government, central and local governance. Some of you may have attended our summit before, some may be here for the first time, and it's a pleasure to welcome you all to join us. Just a few words on the practicalities before we open this session of the summit. The Nuffield Trust, for those of you who don't know us, is a health policy and research think tank. We look at a wide range of issues relating to health and social care policy and delivery. And with our summit, we try and provide people working in healthcare and policy with the opportunity to sit back and reflect on some of the big issues of the day, perhaps not the most immediate, but some of the most significant. And in this session, we're going to be looking at some of the tensions in our health system in the UK, but particularly those around centralisation and decentralisation. There's a often quoted trope, which I'm not sure is true, that apart from North Korea, the UK has one of the most centralised systems of governance in the world, and that to some extent also applies to our health system. If you've missed some of the earlier sessions in the series, you can catch up on the Nuffield Trust website. Our sessions last week covered the role of evidence and science in policymaking, and yesterday Abigail Woods, professor at the University of Lincoln, with a panel chaired by Richard Humphreys from the Health Foundation, looked at the pandemic as a catalyst for change in the health services. And if you missed those, you can watch them back by going to our site. We're really grateful to everyone involved in helping to make these events happen. In particular to our sponsors, MSD and Optum, to our media partner, BMJ, to our fantastic events team at the Nuffield Trust who've adapted to a whole new way of working, and team at Glasgow's who are working behind the scenes to make this platform work. This session is an hour and a half long, slightly longer than some of the things we've done previously. It's live streamed. You can watch it again if you feel so inclined. There's a Q&A box. I expect many of you now are increasingly familiar with this. Please use that on your screen to submit questions as we go along. Sarah Reid, who is a senior fellow at the Trust, who I'll be talking to a little later about some of her research, will be summarising and synthesising questions for the panel. At the end of this, we're going to send you a link to an evaluation survey to get your feedback. So please do take a few minutes to fill this in. It helps us improve. And of course, we're great fans of Twitter, so please feel free to use the hashtag NTSummit to tell people what you think about what you're hearing. The running order is we're first going to hear from Professor Scott Greer from the University of Michigan, who is a student of political science and policies in the European Union and has been a long-term associate with the Nuffield Trust, worked in the past for the University College London Constitution Unit on looking at devolution. So although he's a long way away, he's got a very keen eye for what's happening across the whole of the European Union and indeed us. I will then talk to Sarah Reid about some of the research that she's been doing and reflecting on what we've heard from Scott. And then we have a panel, which I will introduce when we get to it, who will pick up some of those issues and explore them. And at that point, we'll have an opportunity to interact with you as the audience. Now, because Scott is in Michigan, which is quite a few hours behind us, we thought we would not wake him up very early to make him talk to us live, but he's very kindly recorded us a short video setting out some of the key research that he's done in this area and some of his thoughts on this topic. So I'll now ask if Glasgow's can run our video, and we'll then come back and reflect on that. Thank you.
Thank you so much for having me here. I wish I could be with you in person, but instead I hope we're ending the long period of doing everything from a cubbyhole in the basement. I'm Scott Greer of the University of Michigan, and I'm here to present a few of the lessons of what we learned from and about organization during this pandemic. And I want to highlight essentially two things. One of them is the importance of understanding different kinds of centralization and decentralization, because across Europe and over the course of the pandemic, we saw very different kinds of behavior in terms of what exactly government centralized or decentralized. And I hope to propose a way to understand what they were doing. which is the politics of credit and blame. Now, I'm speaking alone, but I'm drawing on the work of a lot of other people. I want to particularly highlight two things. One is the European Observatory's Health Systems Response Monitor, which was a very large international collaboration to track what health systems and health policymakers did in response to COVID-19. And if you haven't had a look, it's wonderfully addictive. And also the book Coronavirus Politics, of which I'm an editor. It's coming out in April, and that rounded up 67 authors to discuss the experience of the pandemic in 34 countries and why governments did what they did. So that's not so much me plugging the book, although it is, as it is, I didn't just make this up. There is a pretty substantial evidence base behind this. So the first thing is when we talk about centralization and decentralization, we saw a lot of centralization early in the pandemic. We've seen some decentralization since then, but what do we mean by that? And it's really important to distinguish two things. The first is centralization within government. One of the things that you saw very pronouncedly, if you think back to those crazy days of March and April 2020, is precisely the extent to which suddenly it seemed like the prime minister or the president was personally running every part of a country. They were constantly doing their press conferences. Ministers were shuffled off to the side. Theoretically independent agencies suddenly were at best window dressing behind the prime minister. They were giving us an example of the dreamed of health in all policies, but not in the way you would personally expect, where Emmanuel Macron or Boris Johnson or any of the other prime ministers of Europe suddenly really looked like they were trying to micromanage their entire country. And that was a real pattern of centralization. Instead of normal cabinet or civil service governance in country after country, you saw ad hoc committees which reported directly to the prime minister. You saw emergency legislation, which strengthened the prime minister's ability to give people orders. You saw formal and informal reduction of the powers of autonomous agencies, such as Public Health England, but even ones that are theoretically more autonomous, such as the ones in France or Germany. So when you say centralization within government, what you mean is the extent to which the prime minister, ad hoc committee, maybe a couple of other ministers, is really running the country at the expense of the people who are normally in charge. And across Europe, we saw a lot of that. It's easier to list the exceptions, which effectively amount to Germany and Sweden. One of the major reasons that Sweden had the experience it did is that the politicians respected the autonomy of independent public health agencies, when in most of Europe, they didn't. The other kind of centralization is between governments. And it's what you saw when, for example, there was a very big power grab by the Italian central government at the expense of its regions. It's where you saw the effective replacement of Spain's fabled regional governments in many areas for a couple of months in 2020. That's when central government as a whole takes on and reduces the power of local and regional governments. We saw both of these early in the pandemic. And we saw a lot of pressure that emerged from that as the pandemic wore on and as we all became predictably tired and grumpy. Well, what was happening? What's the broad lesson we can take about politics from this weird pattern? Well, the way to think about it is that early in the pandemic, it was time to be a hero. There was an enormous amount of fear and a lot of adrenaline, and we know that this is how disasters work. In the first round, there's a lot of creativity and adrenaline and solidarity and kindness and clapping for NHS workers. And when a politician sees that, that is a parade that they want to get in front of. So suddenly, centralizing everything unto the prime minister looks like a great idea because it lets the prime minister lead, it gives them all sorts of opportunities to make policy, and it lets them operate in an environment when there isn't much blame going around, really, because it's so apparent that this is a disaster beyond what we could have expected. So early in the pandemic, much centralization, prime ministers personally running everything down to what you plant in your garden or whether or not you start sour bread baking or yoga. But as it wears on into the summer, remember the summer, cases were getting very low. It looked like things were pretty much under control. If you want to avoid blame and gain credit, what you start to do is flamboyantly announce openings. And there's really nobody who's better at this in the world, as far as I can tell, than Boris Johnson, at flamboyantly and charismatically announcing that something will be reopened and we can have fun again. Remember Christmas. So there was a lot of incentive for these politicians to have one last fling of centralization and say, now I'm going to take the credit for having vanquished it, and you can go visit your families. You can go on holiday in Spain. You can have something like normal life. Fast forward a little further, and it's autumn, and the thing that we all knew was going to happen is happening, which is there's another wave coming. In this time, as you would predict from the history of every other disaster and pandemic, people were getting tired and grumpy. Nobody wanted to be closed up into their houses. The days were getting shorter, the nights were getting longer, the weather was getting colder. It was a distant memory of doing yoga and clapping at 7 o'clock. And so suddenly you had this fascinating phenomenon in which decisions were slowing down and becoming a little bit hazier and getting leaked ahead of time. And you started to see more ministers, and you started to see fewer press conferences by the head of government, and you started to learn about agencies that you'd never heard of before. In other words, politicians decentralized when they began to see that action entailed more blame than credit. Because in the autumn of 2020, there was a lot of blame to go around and not much credit. There was blame for locking down again. There was blame for new public health measures. There was blame for spiking cases. There was blame for an overstressed health system. And so, after politicians had gone through the phase of it's time to be a hero, suddenly they discovered the wisdom of making their health minister or regional ministers or local mayors very prominent. Ask anybody involved in local government in Leicester how much fun that is. So, given that dynamic of credit and blame, you can explain a lot of what happened. You can explain, for example, the politics of the response that we saw in the United Kingdom, in particular England, because obviously one of the things to the credit of the UK government is it didn't take the opportunity to launch an all-out attack on the devolved governments in the way that you saw in some other countries. But you saw a UK government that centralized even by its normal standards, right? Especially with test and trace and the remarkable disrespect shown to the existing local health and local government resources that I think could have been much better utilized. You saw it to some extent in the fights picked with, for example, Wales and Leicester, Manchester, and Liverpool, and also in the abrupt, we'll call it a reorganization of Public Health England. And in each case, it was a sort of ingrained sense that not only would there be credit for the center if it were to run everything directly, but also that as a result of previous policies, there wasn't the local capacity. There weren't enough labs to run testing without something like NHS test and trace. Of course, once things started to go wrong, particularly late into the winter of 2020, then suddenly localism began to be rediscovered. But at the same time, the ministers realized that they did not have a good way to cast blame or gain credit for what was done by the NHS, which is probably why you see a reorganization of the NHS in England coming up. In the rest of Europe, they don't have two things that characterize English politics. One is that nobody in England believes local government runs England. Nobody. You might wish that it were more powerful, but realistically, voters do not vote on the basis of local government performance or believe that it's all that powerful. So beating up local government is basically a non-starter in politics. And likewise, voters have a very hazy idea of what NHS managers are like. And while we can be very impressed by Simon Stevens's political autonomy and acumen, most voters, of course, have never heard of him. Which means that in the politics of credit and blame in England, you start from a really centralized place. And this has produced the pendulum that characterized English health policy for decades, between decentralization, most recently Lansley, the effort to create something that is local and responsive, and above all, to somehow induce voters to blame somebody other than the minister for things that go wrong. And then centralization, when you give up on that and you say, what we really need is the ability to be in Whitehall, knock some heads together, get the NHS to do what we want. So you could say this is just one more swing of the pendulum, one reflection of the frustration which the ministers previewed with Public Health England at having a structure which was in a sense designed to be distanced from them and then turned out to be actually a little bit more distanced from them than they want. So what lessons can we take away from this, apart from the ongoing pendulum swinging in England, where a lot of good legislative cleanup, pragmatic ideas are paired to the desire to get more of a grip on the NHS? Well, one is very basically take away the importance of centralizing within versus between governments, because they're not the same thing. And if we go back to the Swedish example, the Swedish prime minister, almost uniquely in the world, the only examples we can find otherwise are South Korea and Colombia, decided to let his public health agency actually do the ambitious job that was laid out for it. And as it happened, the public health agency voted for herd immunity, and I think we all know the story. The unlikely image of Sweden being the darling of the world's libertarians. But otherwise, expect to see politicians, when there's an opportunity for heroism, centralize a lot. Expect them to get frustrated when they aren't listened to, even if that's by design, as with the remains, whatever you call the decayed remnants of the Health and Social Care Act that we entered 2020 with. And also expect them to start urgently looking for somebody else to take the blame when there's more blame, less credit, we're tired, and we're grumpy. And so you see the ambiguous politics now that you see in England, where they're trying to take credit for the vaccinations and at the same time make sure that somebody else is left holding the bag for the perceived failings of the rest of the system during the pandemic. And if they can get it to work, then, we might have another Johnson government in the next election. So credit and blame are very simple and very crude, but they're a great way to understand both little day-to-day things, reorganizing Public Health England on a late August Friday when you would think no voters were paying attention, and also big things such as the changing prominence and activity of your prime minister or your president during this. And on one hand, you can say this is good. You can say that this is the command and control that the World Health Organization recommends. But on the other hand, speaking from the United States, thinking about Brazil, for example, concentrating agency in one person at a time of crisis does make you unusually dependent on that agency. That was the flaw in the system that people as different as Andrej Babiš in Czechia, Narendra Modi in India, AMLO in Mexico, Bolsonaro in Brazil, and Trump in the United States all showed. You're lucky if your incredibly powerful prime minister happens to be somebody of the intellectual quality and responsibility of a Trudeau. You'll probably survive if it's a Sanchez from Spain, but if you put that much power or allow one person to gather up that much power, you might find that command and control is in the hands of somebody that you actually don't really trust. So you can try to localize a little bit more to gain resilience, but you also need to pay attention to the antibodies within the system, because when politicians want to be heroes, it's very easy to let them be heroes and very easy to realize that you made the mistake later on. Thank you.
So now I'm joined by Sarah Reed, who's one of our senior fellows who's been researching this area. And we've been interested about the extent to which quite a lot of the discussion on centralisation and decentralisation has been framed in terms of how far it's to blame for some of the questionable decision-making that we've seen during COVID, most notably in test and trace, for example, but also in other aspects of our response to the pandemic. Sarah, I'd be interested to see what you took from what Scott was saying there, and how far is it fair that we can put some of the blame at the door of our highly centralised approach?
Yes, great question, and good morning, welcome everyone. So, yeah, I think Scott really helpfully set out some of the dynamics that are certainly at play that can maybe help explain the UK and England in particular, there are tendency towards centralization. But when thinking about how much of this is to blame for how we responded to the pandemic, it's, as I've gotten into this, it's clearly not as straightforward as equating good governance arrangements with good COVID-19 outcomes. nor is centralization always the problem or decentralization always the solution. But very clearly, though, I think our pandemic policy has thrown up some really important questions about which decisions need to be made at what level and when in command and control might break down, and the types of decisions it's good at coping with and those that it isn't. And there's some really real interesting differences in how this has played out in other countries with very vastly different approaches to governance and decision making. And I think that's why you and I are so interested in this question, what those differences can perhaps teach us, if anything, about how to improve policymaking and decisions moving forward.
Well, let's pursue that a bit. So France has really, since the Jacobin and Napoleon, has had this reputation for centralisation. What's been the picture there in your assessment?
Yeah, I think France is really interesting, and it reveals that we're certainly not the only country that has kind of reverted to more command and control structures throughout the pandemic. So in France, as you say, its government policy is generalized, characterized by a very high level of centralization due to some of those entrenched Jacobin institutional features of the French state that kind of favor top-down powers. And when you speak to experts in France, it's really interesting how they say that, you know, having more local-based management of the pandemic was really inconceivable at some points, given those structures. So things like lockdowns and rules had to be applied everywhere, regardless of severity or what outbreak looked like in different parts of the country. So there's a really strong emphasis in the Constitution and kind of their government around solidarity that kind of prevented, researchers say, the government from taking steps to give preferential treatment to any one area or population. And that meant that some of the decisions made weren't sensitive to those regional or local variations and the differential impact that the pandemic has had in different communities.
I think they were a bit more nuanced in the approach to their second wave, weren't they? How did that play out?
Yeah, so I think it's really interesting, and this struck me about Scott's presentation, is there has been this shift, and we can maybe look at politics to understand maybe some of the motivations of that. But there was definitely, I think, in the second wave, a shift to more local approach with and where more localized measures were pursued in terms of how to handle lockdown and some of the rules. But it was interesting that there was actually some criticism that, well, when you leave it to local decision makers, then some of those decisions weren't strong enough in what was needed to curb transmission. So we see that blame shifting again. So I think, yeah, again, it reinforces how complex this is and how it's really not one-dimensional at all and how this plays out.
I think it also emphasises the importance of what policy analysts often call path dependency, which is the extent to which your previous institutions and history did very much determine what you do in future. And Germany, I think, is very much an example of that as well, isn't it? I mean, in the early part of the pandemic, there was a lot of talk about how Germany's much more federal structure had led to much more agility and more spare capacity and an ability to mobilise. But I think the picture's not quite as rosy as that, and they've discovered some of the limits to federalism as well, haven't they? What did you find when you looked there?
Yeah, Germany, as you say, is really interesting in terms of how federalism was kind of hailed as one of the keys to their relative success. But it is, of course, as with anything, more complicated and nuanced when you get closer. So yes, it's decentralization is certainly an asset in some approaches. I think a lot has been made about their ability to have a localized test and trace system. So rather than have a nationalized approach, they were able to mobilize and use local lab capacity in a way that maybe perhaps we in other countries weren't. They relied a lot on local public health expertise in a way that's quite desirable looking back. And they were able to have a strategy that worked well in lots of different local contexts. But equally, decentralization came up as a challenge in other areas. So early in the pandemic, when health systems were having to mobilize staff and workforce really quickly and shift people into new roles in new areas, that was quite hard when a lot of workforce decisions in Germany are handled at more of an individual hospital level, and therefore really hard to coordinate some of these big complex decisions early on. So yeah, not one way or the other.
So I think the federal government also had to step in to stop the Länder from competing with each other and outbidding each other for PPE, which we also saw in the States, of course. I mean, one of the intriguing things about both Germany and the Netherlands, because they're somewhat more decentralized structures combined with this what from the outside what looks like a very complex and quite bureaucratic approach to sort of involving social partners in decision making did at least mean that they had many of the relationships and ways of working already functioning well. Briefly, let's just touch on Spain. Spain has a Ministry of Health, but its powers are quite limited. Most of the heavy lifting is done at the autonomous community level, who generally have ministers who are elected in charge of them. Any interesting lessons to draw from the Spanish experience?
Yeah, I think Spain throws up a lot of interesting questions potentially about the role of the center. So there we've seen an interesting dynamic play out where local areas, as you say, had a lot more autonomy to make decisions about the timing and when to ease lockdowns based on their local epidemiological situations and local healthcare capacity. But what happened there was the center didn't really define what that should look like and what that means. So, what incidence rates should be, what healthcare guarantees need to be in place to reopen. Those things weren't set and defined centrally. So there's a lot of variation in how it happened. And talking to experts in Spain, I mean, there's a feeling that some regions potentially reopened too quickly, and that's what's kind of helped lead to these further surges in transmission that we're seeing now. So a lot of idiosyncrasy, I think, in how we approach this question, and it's overly simplistic to see as one way or another, and there's clearly a role for both, and I think that's something that you'll be tackling in the conversation next with our panel.
So we've been going around this cycle of saying we must devolve, we must put decisions closer to the clinical front line. We've had experiments with devolution during George Osborne's tenure at the Treasury. It's not clear always how much we mean it, and there has been a bit of a cycle. What's your assessment on where British policy is on this at the moment, and how much progress have we made? Are we still the outlier that I fear we are, or how might we think about this when we start talking to the panel?
Yeah, it's again a really interesting question. I think if you just read policy documents from the past decade or so, you might be surprised that we're still having this conversation given that rhetoric around localism. And I know the panel will have really interesting views on what decentralization actually feels like from those working in the system. But I think for me, when answering this question, it depends so much on what we mean by decentralization. And there's lots of different ways and frameworks to help us define and understand that. And Scott alluded to some important examples there. But I think for me, I would want to look to at least 3 areas to understand how we compare. So 1, where is power being transferred? 2, what power is being transferred, and then how is power being transferred? And some of the things I'd look at in each of those. So for where, I mean, as Scott was discussing, where is decisions being shifted? Is it happening between higher and lower levels of government? Is it between politicians and technocrats? Is it between the public and private entities? All of those would introduce a different dynamic, and to the extent to which things are truly decentralized. And in terms of which decisions are being transferred, so are we talking about financial autonomy? Is it control over budgets and how resources should be allocated? Is it more operational decisions around how staff are paid and managed? Is it more policy decisions about who sets standards and targets? All of these would make a difference, I think, to answering that question. And then there's lots of factors that can constrain or limit that autonomy. And that's, I think, what I mean by the how. So yeah, what are the strategic importance of the decisions that are even being delegated? What level and control of scrutiny does the center maintain over those decisions, even when they are passed? So I think those are the things that make a difference here. And it's of course not straightforward. And I think our panel will be able to illuminate a bit about how you get the balance right between those things. But that when you unpack those, that's where we start to look a lot different.
Thanks, Sarah. I think we might also be asking our panel about what's driving this, because I think that's one of the questions that you and I have also been puzzling over. So we'll say thank you to Sarah at that point. She's going to be back because she's going to keep an eye on the Q&A box. So we ask you all to give us your thoughts, comments, and questions. And now I'm joined by a a panel to help explore some of this, and to also perhaps take a slightly wider view than just our often quite narrow NHS view. So Layla McCay, Dr. Layla McCay, is the Director of Policy for the NHS Confederation. She's got a long and interesting biography, which I won't read out to you, but is in the accompanying the accompanying material for this. But has a background in international work, working for WHO and the World Bank, and for the and also more latterly the NHS Confederation, taking a view about Europe. Sarah Pickup is the Deputy Chief Executive of the Local Government Association, and has been associated with our summit on and off for the last decade, and will bring a local government perspective. And Rob Sargent is currently the Chief Executive of Optum UK, but has a background in as a very senior officer in the UK military, and I think there may be some reflections that he might want to bring that as well. So thank you for joining us. Hopefully I can now see you. Excellent. So we've heard Scott very much using the calculus of credit and blame being the driving force that's leading the UK to be so centralised, at least in its response to the pandemic. More generally, one might take a view that some centralisation is a bit of a response to the anxiety about being accountable, particularly in our system with a quite critical press and a tradition of centralised power that people are worried that if they don't somehow have control, that they'll be blamed, and that they therefore need to accumulate central power to deal with that. But I guess there might be other explanations, and how far do you buy Scott's thesis about that, and do you have other thoughts on where that might come from? I'll perhaps come to Sarah first, because I think it might be also interesting to reflect on the relationship of British government more widely to issues of localism. Sarah, what's underlying all of this, do you think?
Thanks. Well, it was a really interesting presentation, wasn't it, from Scott? And I get that thing about credit and blame. I think that there's something there about control. And I think it's political, but I think there's also something embedded in the official underpinning of the way in which our country's politics and its policies play through. So the ownership the civil service have got of policies the government have, and the responsibility they feel they've got to see them through. I think there's something about having a high level vision about what you want to do and how you want things to be, and then worrying that if you let go, somehow it won't be exactly how you wanted it to be, it'll be different. So I think sometimes that's dogmatic. Sometimes it's just that people have got very strong views. I think there's a real lack of recognition in this country, which has been apparent recently as well, of the role of local accountability. We have locally elected politicians too. They are accountable to their local citizens. It's not that all the accountability goes up, but that is how it's perceived, I think. It's the opposite of subsidiarity. Decisions being made closest to the point at which they have an effect. It's kind of upside down, isn't it, if everything is centralised. I think that on the blame side, things have been devolved in recent years, and in some places, and some of that has been a genuine experiment in doing things differently. But historically, what's been devolved is the problems, like how to pay for care homes. That came over to local government, a few decades ago. Local council tax support, local welfare payments. They've been devolved because there was a problem, mainly involved with capping the spend. So they came across, and actually they have been managed locally, because councils have to do that. They have to balance their books, and therefore they do, largely. Occasionally there's a blip. So I think that there is, the blame and credit thing is important, but I think that the accountability, recognition that there is a different sort of accountability as well, needs to be built in. I think there's a place for both. I don't want to say, everything should be decentralized. We can come on to that later, I'm sure.
Yeah, thank you. Layla, do you think the critique of the NHS being highly centralised is, am I overstating that? What's your perspective looking at this from, again, you've got this international perspective as well as knowing the NHS well. Are we a bit of an outlier or not?
I think you're overstating this. I think that it's pretty clear the NHS is quite a significant outlier if you look across the world at the different ways that health services are organised. We are clearly one of the more centralised health systems in the world. And looking at things, it really feels like we should resist the temptation to centralise it even further than that. You know, I mean, if you think about the Donabedian model, there are real benefits for structure, process, and outcome to be managed from different places, and that really works well within the NHS. Our members tell us that it's incredibly helpful and important for the functioning of the NHS to empower local leaders to lead. And what we see when those structure, function, outcome functions start to blend is that becomes more challenging to meet the local needs at the level to benefit the communities that they're trying to do. Obviously, you know, we need clarity at different levels. Who's responsible for setting the strategy? Who's responsible for operational delivery? And who should have the responsibility for assessing the outcomes? And, you know, there are real risks when you start to blur some of those. Looking internationally, of course, there are different approaches all over the world, but I think that we can see that the NHS certainly goes for a more centralised model. If you think of countries, I mean, we already heard lots of really helpful comments from Sarah about how countries have approached COVID, and I think that, you know, there's reflections on how countries have approached COVID as to their general levels of centralisation or decentralisation. If you look at countries like Denmark, Sweden, Australia, Canada, I mean, the responsibility for funding and delivering those healthcare services is largely devoted down to regional government level. National ministries of health are more focused on the strategy and funding of that. If you look at something like Germany and the Netherlands, based on the Bismarck model, you know, central government's got very little role in the planning and delivery of healthcare. What we're seeing here in England is this real interest in bringing various parts together that has been exacerbated by COVID. And I think this is a really important opportunity for us to sit and look and say, what did we do during the emergency stages of the pandemic? Why were those decisions made? And what can we learn from that going forward within the NHS?
Yes, thank you. I think that this question about what spotlight does COVID shine on this is a really interesting one, and it does strike me that many of the things that have gone well have been delivered by the NHS and local government, and things that which frankly have gone to hell in a handcart of things like test and trace and some of the procurement, not all the procurement, as we said, vaccines have been a success. Rob, I just perhaps bring you in here, and you might want to sort of both reflect from your current experience in a large multinational company, but also perhaps from your military experience, because I think a number of people in the NHS who particularly have been working with the military have pointed to a quite different approach to the way that the command and control system works. Command and control in the NHS is a euphemism for central direction and being told what to do. But perhaps just get you to reflect on that and what like the response to COVID might shed on that from your perspective.
Yeah, thanks, Nigel. I should probably start by making an important caveat that you know, I haven't worked for the NHS, and so you know the observations that I'm making here are really based upon talking to senior leaders, reading and so forth. So I'm very happy to stand corrected on anything that that I say. My observation would be that actually I'm not sure that the NHS, that the MOD is more decentralised than the NHS on a kind of day-to-day basis. Where I do think this is different, though, is that the way that it responds to, let's call it an operational imperative, right? Whether the operational imperative is a pandemic or it's a military campaign. or preparing or even training to do that as well. Because I think that what the NHS does when it is faced with the operational imperative is it goes to the command and control system that you have referred to, which is that it goes from any sort of decentralisation to actually being a very rigid command and control system. And the military certainly seeks to take a different approach to that, and instead to use something called mission command to allow a decentralisation. So what mission command is an approach to how you operate effectively. And what it says is that, within a framework of ensuring, at each level of the organization that people are acting within the higher commander's intent, and that they have an understanding of the operational imperative that they are facing, each layer of command is expected to demonstrate freedom of action to achieve the task and to take risks as well to do that. And what that results in when it works well is that you end up with a position where you have empowered leaders who are on the ground, who are able to react rapidly to the unfolding events that they can see as they happen around them, who can take the initiative in a really decentralized way, and that ultimately that leads to better decisions that are taken more quickly in a more dynamic way as well. So that's the kind of those are the benefits of mission command, if you like, and I think that is something which the military does do well. It's not easy, and it doesn't always get it right. General Stanley McChrystal, a US general, wrote a New York Times bestseller, no less, called Team of Teams, based on his experiences as a very senior commander in Iraq, when he went in and discovered actually that the force that was already there, a coalition force, of course, including British forces, was losing because it was absolutely not adhering to the principles of mission command that we had talked about there, and it ended up in a very centralized response system, very command and control system. So, and he then sort of rewired it then over the course of the second half of his command to actually get after mission command and be much more decentralized and be much more successful as a result. So I hope that gives you a sense of the military approach and introduces the concept of mission command to the discussion as well.
Thanks. This question about how risk is thought about and responded to perhaps just explore that a little bit, because I think one of the critiques that's often made of British public service is a level of risk aversion and a sort of sometimes a lack of willingness to make decisions because of the perceived risks associated with that. Is that how's that dealt with in that context?
So I think that a key part of the of operating within a decentralized way in terms of taking risks is understanding what risks really need to be bubbled up to the center and what risks can be dealt with at a kind of more local level, right? And I think that it's the reality is that you're always dealing with, aren't you? One of the reasons that I think that you end up on organizations go on this kind of sine curve between decentralization and re-centralization. One of my favorite quotations is, the empire long divided must unite, long united must divide, thus it has ever been, which is the opening lines to a 14th century Chinese novel called The Romance of the Three Kingdoms. Yeah, and I think that gives that the reason I talk about it is I think it gives a sense of the sine curve that all organizations are on. As they try to navigate their way between the benefits of centralization, which is to say greater control, oversight, grip, reduce risk, that's what you get when you centralize, versus the advantages of decentralization, which involves more risk, but involves empowered people, empowered leaders, better decisions ultimately, even though it comes with more risk as well. And I think that you asked me about the commercial world as well. My experience is that the requirement to navigate those different things absolutely applies there as well, as much as it does in the military or indeed in the healthcare system as well.
Great, thank you. I'm going to come back to Sarah. Started us off with some quite interesting thoughts about what's the underpinning of this issue, and I wanted to perhaps explore, Sarah, if we could, this question of why is it, do you think, that government went to Serco and Deloitte rather than to local government for test and trace, for example? I mean, what was going on? What was going on there? Because it looks like maybe a lack of trust, or they didn't know how to deal with local authorities, or perhaps 10 years of austerity meant that they felt that local authorities had been stripped of the infrastructure to do the job. But what was happening there? Do you think? What's the belief system that underpinned that set of decisions? Have you any insight into that, or can you at least intelligently speculate?
It's speculation, but I think there is something about, if you were being cynical, you might say, yeah, the government knew what they'd done to local government and therefore realised they weren't very well resourced and didn't know if they could step up. But that is cynicism. I think actually it was about a lack, there's a real lack of knowledge about what does happen on the ground and what capacity and capability is there, and the people making decisions are very far detached from knowing what a local public health team does, even knowing that they do test and trace and track for a variety of diseases, okay, on a very different scale to the way in which we're doing that now. And I suppose they thought, well, that's going to be really hard. This is going to be a really big thing. We better bring in some people who are good at logistics and so on. But of course, there was a place for both, isn't there? That you did need some kind of national coordination, and for example, you wouldn't want to procure vaccines, in the local area. But in test and trace, it just went all one way, didn't it? So we're going to have and also there's this attraction, isn't there, for some of the personalities of the world-beating system, and it's not a world-beating system if it's good in Cornwall and it's not quite so good in the London Borough of Haringey or something. It's so they don't get they like the idea of uniformity as well. But I think the test and trace one is one where that really didn't work, but some of the bits of work, or albeit there were frustrations when we were doing them, a national framework and enablement and funding that went with discharge to assess funding or shielding support, and then enabled that to happen in the way that was most appropriate in a local area, is actually a piece of learning for the future. Well, actually, we've known it. Many of us have known it for a long time, but it's less has become more accepted, I think. But it does require, it shows when you put the right pieces in place, you can enable and empower things to happen. But I think that the testing thing, it was such an ambitious thing. And also they decided not to even go with the known apps, didn't they? They decided to develop their own app and then had to start again. And it just felt like it's because the decision making is so detached from the reality. And just back to that risk point, one final point on risk, that there are plenty of risks of doing things in a centralised way, as evidenced by the test and trace programme, which is that there's the risk of unintended consequences. If you don't know what happens at a local area and how things actually work in practice, which was evident in some of those other things that were devolved I mentioned previously, you get unintended consequences, and that's a big risk.
Yes. That's Layla, what's your take on that? Because I think the NHS has a better record at understanding the front line from the centre, but it's not entirely immune from some of the things that Sarah's been describing there, is it?
Yeah, absolutely. I mean, I think that in terms of the NHS leaders, what they want to be told is what they should be aiming to achieve in terms of outcomes, but then empowered to get on to figure out how they're going to achieve that in the way that feels best, in the way that is the most suitable for their particular situation in terms of their resources, their community setting, the challenges within that particular population, the strengths within those populations. And really, when we look at things on the national basis, then some of those advantages are really lost. Sarah's quite right in that sometimes when the scale of a task seems so huge and that we know that it's going to affect the whole population, then there really is this temptation to seek economies of scale, to deliver this sort of national based approach. But I think that our learnings are that we're seeing there's significant successes when this local expertise is able to be deployed, and there are real risks going essentially over the head of that local expertise. We've seen that very clearly within the test and trace program, which has of course been so expensive. And when things are so expensive, you can understand why the governments would feel like they needed to have that extremely close level of accountability. But it's, as I said before, it's not always the case that the people who have the strategy should be the same people who are trying to deliver, and the same people who are measuring outcomes. Those functions do not always work well within the same set of people. And I think that there are very clear learnings here about the benefits of local leadership that we would do very well to focus on going forward.
We hear a lot about economies of scale. By the way, we might just question just how much accountability is being held by people responsible for test and trace, but that's a debate for another day. But the economies of scale point is an interesting one. I mean, I wonder, I've often wondered, looking at the NHS, about what, and this probably may be true of central government too, which is we tend to overestimate the economies of scale that are available to us and underestimate some of the diseconomies of complexity and the lack of local contextual knowledge and some of the other downsides. And the empirical basis for actually saying we've got economies of scale, I think it's a bit thin. I wonder what any of you think of that line of inquiry. Is it, am I being overly pessimistic about this, or is it just a sort of helpful mantra to encourage further centralisation?
Shall I come in? I think,
yeah,
obviously, I think we probably tend to use the economic term economies of scale across too many things too much of the time. And we just, you know, if you use that, you assume bigger is better. But actually, and of course, if you're buying a load of pencils, or you're even buying a load of beds or bits of equipment, you probably can get economies of scale by pulling contracts together and, you know, and pooling your spending power. So for buying stuff, you know, there often are economies of scale. In managing organizations, of course, you reach points like step changes, don't you, where you can only do so much for the capacity and you have to go up to the next level. And actually then your economies dip down again before you kind of maximize the use of your resources. And in some businesses, like if you think about the home care industry, some of the really big providers actually end up being more expensive per, you know, for the services they provide, because of the overheads that are involved in managing that small business, which actually delivers at a very micro level on the ground. So yes, I did a degree in economics. Economies of scale, yeah, we should look at them, but we shouldn't presume that they apply equally to everything. And we should, you know, just stand back and think about the benefits of small, you know, small is beautiful, the other, you know, kind of mantra that you could use. Yeah,
yes indeed. Layla, yeah.
I would absolutely agree with that. I mean, part of this is the local arguments that often, you know, a solution can be delivered at local level that works for that level, and that turned out to be the economy. I think that there's clearly not any hard and fast rules here. Really, a bit of flexibility and pragmatism is needed if you're thinking about where those kick in. I mean, I'm thinking, for example, about some specialized commissioning services would lend themselves well to devolution, or, you know, system level or clusters of systems. I'm thinking of things like, you know, renal dialysis. Other things are very rare within populations and high cost, so of course better retained at the regional or the national level. I think it's quite interesting. The variation in ICS size and maturity does offer that opportunity for systems to collaborate on all these different sort of supra ICS scales for all sorts of specialist commissioning to reduce financial risk. And I would say, of course, that equally it's right that sometimes there are national programs in certain disease areas. And so I think
getting the blend right seems important.
That's what I was going to say. A blended approach is going to have to be the right way forward here.
One of the dreams of the Gauss plan of the Soviet Union in the 1930s was that with sufficient computing power, which in those days was manual, you could centrally plan large tracts of the economy, and we kind of know how that ended, which is, you know, not so well. during the pandemic, it's been very interesting. The deployment of really big data sets of data aggregation of companies like Palantir, creating these huge linked data sets, and to some extent being seemingly used quite successfully for, say, PPE, for moving PPE around the country, and for a variety of other for management purposes. And we know that Dominic Cummings was a great fan of creating a sort of James Bond style control room at number 10 with all of these data flows coming in. I wonder, do you think there's a temptation that the prospect of big data and artificial intelligence decision support systems sort of might tempt people back to some of that level of thinking? I hesitate to quote Hayek, but he does occasionally have some interesting and really relevant things to say, particularly around the what he called the illusion of knowledge. That you think you understand what's happening, but because of the tendency for information to sort of attenuate as it comes up the system, and for you to lose context, you've got the illusion of knowledge, but not actually real knowledge, and therefore your ability to solve the problem is limited. Rob, you're in the data world. I might put this one at you, but I'm going to ask the other two as well. I mean, does new technology offer opportunities perhaps for improved central decision making or more empowered local decision makers? Am I posing a slight, is there a risk here, but probably a bit of a false dichotomy, or what do you think?
Well, I think it's I agree with you. I think that it does. I think that it does absolutely increase the greater risk, because it makes centralisation ever more tempting, right? And the illusion that actually everything can be controlled, notwithstanding the complexity of what's going on, and the inevitable the amount of benefit that you will gain from empowering different leaders at all of the levels, and particularly those who can actually see what is actually going on the ground rather than what necessarily seem to be. I think that, and I think that it actually kind of runs, accepting that you need to run away from that is probably what lies at the heart of successful decentralization, right? I mean, I think that if you're going to, again, thinking about the kind of, the military, which you asked me to think about as well, and to draw on that, my experience from that, we talked about the principles of mission command. Well, clearly they need to be lived. They can't just be kind of talked about. And I think one of the things that the military does is to ask people at all levels, from a lance corporal commanding a 4-man and woman fire team up to a 4-star general commanding an 80,000 person coalition force. They will all be trying to think about how they can make mission command work. What does that actually mean? It means if you're going to successfully decentralize, you need to empower people. You need to ensure that people have got the freedom of action, that they're accountable. Critically, I wanted to pick up on Layla's point here, that you're giving people an intent of things that you want them to achieve, not how to achieve it, right? That absolutely destroys people's ability to use their initiative and to add value on the basis of what they can see as well. And I think that all of those challenges are, those things are key to successful decentralization. And I think that the illusion of command that comes from improved data all the time is absolutely runs counter to that, and I think it's very damaging.
Thank you. Sarah or Layla, do you want to come in on that?
Yeah, I'd be pleased to come in. So
thank you, yes.
I think that data obviously is really important, but actually it's possibly more useful the more local it is. So if you know about your citizens in your place, you can better manage population health than if you've got an aggregated national figure that hides the reality. I think you need, I'm not saying there's anything wrong with having national data. It's good to kind of have a context of what you're doing, your direction, to set your strategy, to know what your underlying problems about. Solving the problems is much more granular than that. I think there is a risk that there's a lot of talk of dashboards all the time. Very popular to have a dashboard on a ministerial desk. And if I think about social care as a kind of prime example, I think we, even at local level, probably do need more and better data. But there is a real frustration that's been apparent at the centre during the pandemic, that you can't pull a lever and sort out something that's happening down in social care on the ground, and that there's a lack of information. And this is because there's a huge complexity in the social care system, isn't there? With the independent sector providers, voluntary, private, some people pay for their own care. I mean, it's hugely diverse. That system has been created by national decision making in the past, you know, by the central rulings that certain proportions of social care had to be tendered out to the market. And it's built and grown from there. And it's been exacerbated by the funding decisions. So there's a real danger that we have a dashboard that tells us we're not all quite doing what we should be doing according to the Care Act, but with neglecting to remember that we didn't put the funding in to make it happen. And in fact, we'd reduce the funding. So I think that frustration at not being able to make things happen on a national level in an NHS command and control style way, if indeed that works quite as well as people think it does in the NHS, could lead back to a desire for more centralised kind of more levers at least. And I think that's a risk, because I think, you know, you'll go back to your unintended consequences of like when they brought care homes into. So think about the time when it was really obvious that people shouldn't be paying for nursing care as part of their nursing home provision. They were thinking about people who are paying for their own care. So great rule. No one has to pay for their nursing care anymore. They just pay for the care home bit, the residential bit. But actually forgot about local government being the main purchasers of care homes and creating a really complex and bureaucratic system between health and social care services. Completely unintended consequence of trying to fix a problem from a national level without taking that local reality into account.
Great example, thank you. I've got Layla and then Rob, and then I'm going to come to Sarah to get some questions from the floor. Layla.
I agree with the others. I've made some really good points. I think from my perspective, when we look at data, it's incredibly important to have robust data, and the opportunities are huge, but it sometimes feels to me that we're still kind of in the infancy of how to make best use of the data that is available. There's so many challenges at the moment with interoperability. There's many challenges with repetition of data that's being called for. That's having ramifications right there on the front line as people are spending huge amounts of time inputting data that they don't necessarily immediately see the benefits of. I think that this is something that needs to be evolved and developed. We see things, for example, you know, people are collecting vaccination data, but there's not much link between local vaccination sites, data systems, and the national data systems. Various efforts are having to be duplicated. It's frustrating to people, and I think that if we're going to seize the data opportunity, we need to really get the interoperability right. We need to get the way of using that data right, and we need to get the whole process streamlined so that it works well without detracting.
I guess in vaccination data, you can at least see why that's being collected. I think there's been a long history in the NHS of people feeling that they send data back into the centre and it's never used or looked at, and it's been, you know, put in a cupboard and never scrutinised. And I seem to remember one trust doing the experiment of seeing what happened if you didn't complete large numbers of columns inside the pack they sent back. And I don't know if ever for some of these data returns, there's been pretty good evidence that they've not really ever been looked at very much, I suspect, but which is of course a bit soul destroying for those producing it, and undermines the validity of the rest of the data. Rob, did you want to come in on that, or shall I go quickly and then I'll go to Sarah?
I just want to make a quick observation about some of the work that we've been doing with the population health management delivery program, which is I think NHS's flagship transformation program in terms of PHM. We're fortunately been going to each of the different ICSs in turn, to work with them to really show them what the art of the possible is with population health management. And I just think that this point about, as Layla said, the opportunity being at the local level, when you can look at the local data and then collate it, navigate the information governance, bring together the data on the one hand from healthcare, but also from things like local authorities. That's really powerful, because suddenly you have real insight for the changes that you can make in terms of A, identifying where the risk actually is across the population, and then B, the changes that you can make to help that population improve its risk as well, and in terms of its next step. So I think I just thought it was a very, very, very neatly put by Layla. I wanted to come in support.
Yeah, great. Well, I'm going to come on to ICSs later because and the white paper, because we ought to pick up some of the issues related to that. Sarah, I see there has been quite a bit of traffic in the Q&A box. What have you got for us?
Yeah, some great questions coming through. So there's been some observations and reflections from different attendees on kind of some of the problems of centralization but how you could make it work better. So I think I'll ask one question first on this theme from Nick Mays, who's a professor of health policy at the London School of Hygiene and Tropical Medicine. So he asked if you could articulate, is it possible to have strong central decision-making that doesn't necessarily constrain how non-central actors accomplish their objectives? Or, will that prevent the center, therefore, from taking credit, and therefore it's impossible to imagine? Are there good examples of where and how that's happened?
I guess we might look to local government for that, maybe particularly, Sarah, perhaps?
Yeah, and it's a really tricky question, isn't it? And I think you can have a good, so it is all about flexibility within a framework, isn't it? And as Layla said earlier, about setting out the outcomes that you want to achieve and then allowing freedom to deliver. And one of the things that is not, so let's think about the CARE Act. So the CARE Act was co-produced with the sector. So actually what's in it is quite well signed up to. Yes, it was centrally determined, but it was done through engagement. There's a strong decision, there's some good ambition in it. The problem was that the things that were needed to really make it happen on the ground, the empowerment, and the funding, the empowerment was there to an extent, but the funding wasn't. So you've got to, if you want to, that could be an example of a strong central decision to say we want to change the way the care system, we want to personalize it more, we want to focus on well-being, there's a duty of prevention. These are all great things. They had a big sign up, and they should be empowering local delivery. And there's probably a couple of reasons why not. One is, a very big one is the funding, because it came in the middle of austerity. And the other one is that the aspirations get flowing through the NHS, and their kind of drivers were different. So I remember when I was a director of adult services in a council, I was being held to account by an inspectorate for my great partnership working with the NHS. But the NHS was not being held to account for its partnership working with the council because it wasn't one of their kind of priorities. So you need to make sure that things tie up to make them happen. I absolutely don't think it's not about that there isn't a central role for decisions, but it's really tricky to get the balance right, but I don't think we've got it right at the moment.
Thanks. Layla, do you have a observation on this question? I'm trying to think of an example of where this has actually been done in the NHS. So he says, having a clearly articulated objective, but with a degree of flexibility about how the objective is achieved.
Yeah, I'm struggling to think of a good example, although I'm sure that there must be some, and perhaps people can pop some into the chat box if they're if they're feeling inspired. I guess that when you look at that question, it's probably quite closely linked to the complexity of what is being asked. Where this sort of level of centralization may work well is, you have an assembly line creating some simple product. That's not the situation within the health service. No matter what is being called upon, significant amount of flexibility and local innovation to make it work at that level is always incredibly important. So I'd be interested to hear what people think, but from my perspective, that a certain level of local empowerment is at the heart of making success.
So I wonder if an example might be the following the Kalman-Hind cancer strategy, where there was very clear goals set out and some principles, but the decisions on the who was going to do upper GI surgery in which location and where the cancer centre was going to be was determined by sort of clinical and managerial group, not at the very local level because of the nature of those services, but across big geographies. And there was a degree of the how set out in the strategy because it had some principles about volumes of surgery and about multidisciplinary teams, but the actual sort of execution and adaptation of that was probably done with more local discretion, probably because of, as you say, Layla, I think you put your finger on a very important point, because it's such a complex area. So there were broad goals, and then there was, so that might be one example where we might point to some success in that area. Good. Should we have perhaps a slightly easier question than that was? Because that was hard.
Sorry, that wasn't fair. I don't know if this one's easier, but let's see how you get on. You are having a really interesting conversation about some of the risks and trade-offs, and a couple of questions have come through on this point, and one's from Jane Dunnage, who's a patient research volunteer, and she asks, what are some of these trade-offs and the dangers potentially for access or quality varying? I mean, with more decentralization comes more variation that can lead to things like postcode lotteries. So yeah, just any reflections on the trade-offs and how to make sure that considerations of equity are still considered and how to overcome that.
Yeah, I don't know about postcode lotteries. I have a slight allergic reaction to the term. I kind of understand. I mean, you never hear from the people who've won the postcode lottery, by the way. I don't know if you've ever noticed that. I mean, there is a fine line between local variation that matches local need and a postcode lottery, I guess. I think. Layla, what's your view on? I'll come to Sarah in a minute, but what's your view on this tricky question? Because there is a trade-off here, isn't there?
I mean, I agree with you. Postcode lottery is usually only used in this sort of pejorative, negative way. But what we're really talking about is the flexibility to recognise that not all communities are exactly the same, and different services delivered in different ways are going to be needed to address the full diversity of challenges. The health and care issues that are faced by, say, a rural community in Cumbria are going to be different to Blackburn or Bolton or Bristol. I guess local communities, local leaders and NHS teams are best placed to co-design the right services and interventions for their communities. And there's a real risk of trying to block the diversity and flexibility that actually enables those local systems to get on and deliver the services that are right for their populations.
Do you hear about postcode lotteries in local government, Sarah? I mean, it seems like
Oh no, never. Yeah, of course we do. Yeah, so postcode lottery versus local variation and choice and local context. So it's really important. I think there are some things, aren't there, where people have an entitlement to things like maternity services, or people have entitlement to childhood vaccine, and those are kind of expected to be delivered in all places because they're kind of seen as core. But for most people, we all want to treat people as individuals, don't we, and look at their life in its whole context. And so you have to shape things according to the individuals and the people and the communities, the facilities and all the things that you've got. And it's also, we just have to bear in mind that funding is also not, the same everywhere. And inevitably places have to make choices about, how they disperse their funding, particularly in local government, where there's a multiplicity of services to fund. So there's political choices to be made between, the citizens who actually will tell you potholes are the biggest priority compared to where you spend most of your money, which is on children's and adults' services. So, there's a fine balance. Just as national politicians make these judgments all the time, we need to remember that there is a local accountability going on here as well, which is partly why it might be different from one place to the next. But I think you can embed some entitlements. There's been talk about whether people with dementia should have an entitlement to certain things, not how they're done, but that, so post-diagnostic support or something should be more readily and more quickly available to people. So I think you can have some expectations, but I do think local flexibility is just crucial to meet population health needs.
Sarah, have we got time for one more, do you think?
Yeah, I guess there's there's one that builds on that nicely. And when you're talking about local variation, then is, of course, every place in the UK is going to have different needs for their own recovery then. And I guess we're starting to see some of the centralizing tendency come out in some of the requirements that are being placed on NHS trusts and others to kind of restart elective services at a certain pace by a certain time. And I'm just wondering how much the panel envisages an option for localities to kind of plan their own post-COVID recovery. And is that a pipe dream?
Just a really quick comment, which is local government is like, so leaders of councils across the country, during this pandemic, there's been groups of leaders who've been meeting, representing local government into central government and working really closely with them on a lot of this stuff, which is kind of how we've come through some of the challenges that we've faced. And they are now stand ready and willing with their thoughts about recovery across the spectrum. Obviously, there's very particular things about the need to get rid of backlogs in the NHS and so on, a very specific thing, but there's a whole set of issues that align with the government's agenda around, levelling up, but let's think about it as health inequalities actually, which underpins that whole agenda. And local politicians just itching to be able to help shape and drive that from their perspective on the ground in terms of what they see will be needed and what will work in their area. So I hope there will be a local flavour to it and local engagement, albeit that I recognise there will need to be national input as well.
Yeah, thank you. Sarah, one more, and then I think we better move on.
Sure, yeah, and this question I think is mostly for Rob potentially, but there are some reflections from delegates that they're really impressed about the approach to the military, and just thinking about, is this something we do well enough? Like, are there other opportunities for greater integrated learning from one sector to another, and where do you see the greatest scope for that moving forward?
Yeah, and perhaps Rob, you might reflect. I mean, one of the things that I was thinking about was what is it about the people development and processes that allows some of the mission command that you were describing? So we might pick that up at the same time as well. So James Morrow is I think you're referring to here. Sarah says, really how much of a revelation it was to work with a lieutenant colonel who took over the chief of staff role. So what are the opportunities there, Rob? And just say a little bit perhaps about the sort of the people and process development, if you would.
Yeah, no, sure. I think it's I think I'll make a couple of observations. I talked previously about the fact that the military will expect its commanders from Lance Corporal up to 4-star General to live this, to live mission command and to make sure that they are living in terms, sufficiently in terms of process. Of course, it's not just that it expects them to do that. It actually, selects, tests, educate, and tests their ability to do it, throughout their career as well. And that does mean that I think that it is something which is deep in the culture. That said, culture can be learnt, and culture can certainly be adapted as well. And I think that it would be really interesting and worthwhile as we come out of the lessons learned from the pandemic. Which are the areas where greater decentralisation has actually resulted in better results? I think there's been through the panel there's been a sort of slight there's been an exploration, hasn't there, of whether or not because you decentralise somehow that you end up with with worse results. I think that actually although it may feel that there's more risk to it, decentralisation is likely to improve results, and as long as you can feed those up, then that then leads to greater acceptance by whoever it is that is holding you to account for the success of what you're being asked to do as well. So if you look across that and agree that things like test and trace, for example, worked better when they were decentralized, I think that is something to kind of reflect upon and to try to think about how what that gives you in terms of decentralization going forward. Yeah.
I mean, Sarah Scobie and asked a slightly less optimistic version of Mark Rowland's question. Mark is wondering whether we might end up with a sort of upside down management, where the management is seen as support for the front line, which has been my experience of working in a private sector organisation, but it does seem a bit unlikely. Sarah's interested in whether or not we might be able to get a bit more of a shift back away from more centralised decision making, and what's the how optimistic are you all on that, and where do you think the white paper takes us in terms of that balance between central and local control? Layla, let me come to you first on that.
Thanks. I mean, looking at the white paper, we know that in future ICSs are going to continue to have vertical accountability to NHS, ENI, and to government. But I think that the NHS Confederation is also keen to see them having that horizontal accountability to their local populations, still establishing what the roles of all the various bodies involved in that will be, how health and wellbeing boards relate to ICSs, integrated care partnerships at place. All of those things are still being figured out. And I mean, at this stage, it's pretty difficult to assess what responsibility and accountability are going to look like within the systems that are developing. But I think that there's an expectation it's going to differ quite significantly across different ICSs. And, you know, having the flexibility is probably going to be key to enable these different bodies and different systems in different populations in different parts of the country to deliver what they need to.
So one of the unintended effects of devolution in Wales was effectively a centralisation of power inside the Welsh NHS. So in fact, if you were a frontline, if you worked in a hospital or you're a frontline health worker, it actually appeared that your system had become more centralised rather than less, even though the power had been devolved. A great deal more power being devolved to the Welsh system government. So it's like a slight paradox here, which is the intermediate level of governance suddenly thought, hold on a minute, we're in charge now. There's been devolution to us, and power was sucked up from the local health boards in Wales into Welsh Assembly government. Is there an issue? And again, any of you, just take this on if you would. I mean, is there an issue here of us actually just creating a different type of centralisation? It's a little bit closer to the front line, but it's worth remembering that the average ICS is bigger than at least one of the Baltic republics. These are not. Some of them are the size of EU countries. So local is not necessarily exactly how you describe them. Manchester seems to be a really interesting sort of melting pot of exactly this tension. Sarah, do you want to take on that challenge?
Yeah. So the spirit of the way the white paper is written talks about greater empowerment of systems, but actually, if you look at Annex B, it talks about primacy of place, which says most stuff actually happens at a level below an ICS system in most places. And the best partnership work between health and councils or the voluntary sector happens at that level. And that should be encouraged and continued. So the principle of subsidiarity is written into that white paper. Now, of course,
you believe that though? I mean,
I was going to come on to that. So it's a good start though, isn't it? Like, it's not starting by saying we're going to centralise everything. It's starting by saying actually things work better if they're done more locally. But for me, working with the NHS and the department on this as it paves its way through and you get through guidance is about what is the expectation? What is the real expectation of what these systems and how they work with the places, or however you want to define it within them, just use those terms sort of loosely. And I think, we've got these two bodies, the ICS NHS body, which is a formal NHS statutory body, and therefore, in my view, could not be a partnership of equals with local government and the voluntary sector. It's got its accountability up to the NHS. Councils have got their accountability. They set budgets, they're accountable to their local citizens up through their councils. And the two things don't align, they don't align. And so you have got to have a way of joining them up to deliver partnership in place. And most of the, as I say, most of that part, even in Manchester, most of the action is at the 10 local authority level. It's not at the ICS level, but they still do that coordination at that level, and they do it in partnership. So the place for the so the accountabilities will stay. The NHS is responsible up its line. The councils are responsible to their electorates and their councillors. But actually, each of them can make decisions to say we're better off doing that with those people over there. And they can pool their budgets. They can create joint commissioning. They can create integrated services, integrated delivery, integrated teams. And they can have a constitution that says we're going to do this together. We're going to put this money together and do these services together. And that's how it works at place level when people do pooled budgets and integrated services. There's no reason why you have to have this clear, of course, it's easier if we were all clearly accountable one way, but we're not. So what you've got to do is work out what works for people on the ground and how can we make it happen. And I think there's a potential vehicle here to make it happen. But what's written in the guidance and what the NHS expects through its performance management regimes is all important.
So there's be an accountable officer who I can, so I live in Hertfordshire, there'll be a Hertfordshire ICS accountable officer and I can ring them up and ask them what's going on. But if I want to ring West Hertfordshire, to quote, I think John Foster Dulles about Europe, if I call Europe, who answers the phone? If I call West Hertfordshire, who's on the end of the phone? It seems to me that the power is very much at the ICS level, and there's a real risk, despite the rhetoric of the primacy of place, that actually, in quite a lot of places, and we see in the HSJ today a story about a real tension developing in Manchester, with a feeling that the sort of the ICS bit is likely to suck up power. Rob or Layla, do you want to? What's your? You can make me more optimistic.
Well, Layla, I'll let you go first, and then I'll have to make a slightly different observation to finish.
Go on, Layla. Yeah.
I mean, in terms of devolution, clearly it offers lots of opportunity, but the question still needs to be addressed as to what that should look like. And I think that from the NHS perspective, we've not always found the time to reflect on the various forms of devolution and what would fit best. But Sarah's absolutely spot on that devolution can't be looked at in isolation from place or in isolation from the economy. And really, there's clear merit in not just looking upwards, but looking outwards. And decentralisation plays a role in that process. But there are many different considerations, and this is a challenge.
Who do I call for West Hertfordshire? Who will I call? Any ideas? Have a think about that.
I mean, I was going to say Ghostbusters, but
maybe Rob.
Well, I just quickly reflected that I don't think I'd answered James's question about the benefits as well of potentially the different agencies sort of trading alongside each other. Yeah, I think that's a great point, and I think we know that there'll be plenty of desktop exercises that are run by NHS England and so forth. The military are often on them. I suppose the question is whether or not we can also then apply that kind of test of whether or not they are being run in a decentralized way, as you're then trying to to respond to whatever the next operational imperative is, right, or indeed the final part of the pandemic.
So we've explored some things that we could do that will perhaps get a better balance between centralisation and decentralisation. I'm going to ask the panel now really just to sort of give me a couple of practical things that they think we might be able to do that would perhaps propel us in the direction of getting a better balance between central and local control in the NHS specifically, but actually across government more generally, if that feels relevant. I think, Sarah, you've already given us a couple of clues on that, so I'm going to come to you last if I could. I'm going to come to Layla, and then I'll come to Rob, and then I'll come to Sarah for a sort of final, give us a couple of things that you think which practical steps that perhaps would move us in the right direction. Layla.
I think that everything that we've discussed today, I was just musing, could be encompassed with a restaurant metaphor. The centre should be telling local systems what kind of meal they would like to have, but it needs to let those systems get on with sourcing the ingredients and cooking the meal in the way that they think best. And I think that could be applied in quite a lot of the decision making that is going down at the moment. Excellent.
Rob, have you got a metaphor or a or some other way of?
No, well, anything that involves going into the thought of going back into restaurants. I mean, I really do. Really gets all of our votes, isn't it? What would I say? I would say, beware the false attraction of centralisation, and the sense that somehow centralisation gives you better results because it reduces kind of risks, and instead, sees empowerment, sees freedom of action, sees accountability, sees the giving of direction through intent rather than through direct orders. Those are all things I think that allow you to decentralize most effectively.
One of the things that came up in a conversation we had with a BMJ roundtable was the Institute for Government talking about how they train their training program for would-be ministers, and that might well form part of the curriculum for that. Sarah, you get the last
first of
word.
all, for West Herts, I would say it's all about how organisations set themselves up, isn't it? If you set yourselves up in a way that expects to interact at a level below your highest level, many organisations do it. They have teams, associates. So there's a way of doing it.
Yeah. So
that brings me to my couple of key last points, which are, this is all about what you expect, what you empower, and what you enable. And we need to, the expectations of the system need to be that it does work in the way we've all been talking about, which is, we have national, frameworks and outcome objectives, but actually people are empowered to get, to work together on the ground. And then my final point would be listen to local.
Thank you. Didn't begin with E, which is a shame. We love a bit of alliteration. I also love it when a panelist provides me with the summary that otherwise I would have to do. So thank you for that, all three of you. And thank you to all of you for joining the session and for your questions. We've had quite a lot of them. We haven't been able to answer all of them, I fear. This is the last public session for this series. We hope you've enjoyed the events. You can watch back at other ones that you might have missed. We're really grateful for everyone who's been involved in this, in particular Optum and MSD, who have been our sponsors, and the BMJ, and thanks to our events team. Thanks to all of you for joining, and in particular today, thank you to our panelists. Thanks very much and goodbye.